Let's talk infection prevention. One of the things we have to be so diligent about when we're talking about IV therapy or blood draw is to make sure that we are maintaining aseptic technique and preventing infection, untowardly. So strategies for preventing infection. Nurses are involved in maintaining VADs or vascular access devices and must have a knowledge base and competency to implement evidence-based interventions to reduce the risk of infection. Now, you all are very, very well versed in infection prevention, but we have to make sure that we're providing the basic foundation for the delivery of infusion therapy. So we're going to get into this and we're going to talk a little bit about it and what it means to you when you do any type of blood draw or even, starting an IV. And it starts with the knowledge regarding the techniques to use to prevent infection. There's standards, we know that. We know hand washing, we know cleansing, but we're going to get a little bit more in depth. So first off, we want to start with the basic knowledge. And so let's talk about the standards and transmission-based precautions. You know what standard precautions are. However, it can never be drilled. I've been in nursing over 30 some years and it can never be drilled in enough. And standard precautions are intended to be applied to the care of all patients in all healthcare settings, regardless of the suspected or confirmed presence of infectious agents. Whereas transmission-based precautions are applied in the presence of known or suspected infections. Although these guidelines apply to all settings, the CDC recognizes the shift in health settings to community-based and ambulatory settings and published a summary guide of recommendations specifically aimed at outpatient settings. So those of you that may be working in a clinic or in a blood draw facility, something like that, yeah, there's a drive to make sure that we're maintaining standard precautions. The specific elements of standard and transmission based precautions are as follows. So first, standard precautions. Now remember, this is the universal precautions. Then they are designed to reduce exposure risks to bloodborne pathogens. And standard precautions are based on the principle that all blood, body fluids, secretions, and excretions, except sweat, non-intact skin, and mucous membranes may contain transmissible infectious agents. Standard precautions include the following infection prevention practices: hand hygiene, personal protective equipment, PPE, such as gloves, gowns, masks, eye protection, or face shields, and safe injection practices. The application of standard precaution is determined based on the type of interaction with the patient. Okay, hand hygiene is a given. Hand hygiene is always, whether it's gel-based, foam-based, soap and water, hand hygiene is always a given. And then, of course, you're going to use other PPE as needed. Like if you're drawing blood or you're starting an IV, you're definitely going to use gloves. So it is all based on what you're doing. For example, with peripheral venipuncture, only gloves normally would be worn. In summary, standard precautions are imposed when there is a risk for exposure to blood, there is a risk for exposure to other body fluids, including secretions and excretions, non-intact skin is present, and there will be contact with any mucous membranes. I cannot stress this enough. These you have to know. You should already know them. I'm preaching to the choir, but I'm going to have to drill those into you, how important they are. 3 additional elements of standard precautions are specifically aimed at protecting the patient. Those are respiratory hygiene, cough etiquette, safe injection practices, use of masks for insertion of catheters or injection material into spinal or epidural spaces via lumbar puncture procedures. We are focusing on number 2 in this course, safe injection practices. So safe injection practices, what are they? So poor infection prevention practices and lack of poor aseptic technique can lead to infections. And so there's campaigns to make sure that we don't have unsafe practices. We don't want to make patients infected. We want to make sure they stay free of infection and make sure we're providing what they need to become healthier. There are some areas of concern, of course, and those are reinsertion of used needles into a multi-dose vial or solution container. What that means is insulin, for example. We're not going to reuse the same needle to drop insulin, are we? Nope, absolutely not, because that will contaminate what's inside that vial. The same thing is going to happen with saline solution. Let's say you're doing a flush. Normally, our flushes are all in a syringe and they're self-contained. We don't have to worry about it, but there are occasions where we have to draw up our saline. And in drawing up our saline, we do not want to use the same needle to redraw that multiple times. Use of a single needle syringe to administer IV medication to multiple patients. Don't want to do that either. Once one and done. Those syringes are one and done. Whenever possible, use of a single dose vial is preferred over multi-dose vials. And multi-dose vials are used only with a single patient. Outbreaks related to unsafe injection practices indicate that some healthcare personnel are unaware of or do not understand or do not adhere to the basic principles of infection control. Now, the use of the CDC injection safety list to ensure that the healthcare organization is adhering to safe injection practices. And so here it is, a little hard to see. You do have this in your files, so you can print it and save it and use it. I will have it as well as a handout when you come for your one day in person. So you will get a copy of this if you cannot print it out. Hand hygiene. We know this. We all know this in healthcare. Hand hygiene has been shown to significantly decrease the risk for contamination and cross-contamination. Touch contamination is a common cause of transfer of pathogens, meaning I went and took care of another patient, maybe just brought him a cup of water, a pitcher of water, put my hand, on them. We do that also often, that personal touch, and without cleaning my hands when I left the room. Did the same thing when I went to the next patient. I can actually, touch contamination can occur, and I can transfer those pathogens. So that's why it's always, always, always imperative that you cleanse your hands every time before you touch a patient. Preparation used for hand hygiene. You guys know this. Alcohol-based hand rub, and it should contain at least 60% ethanol or 70% isopropyl alcohol. And again, we can use that routinely for hand hygiene, unless your hands are visibly soiled and it's soap and water. You should use an antibacterial soap and water, just to make sure that that we're washing off any contaminants. And again, hand hygiene should be performed for at least 20 seconds, whether using an AHBR or when washing hands using a non-antimicrobacterial soap. So recommendations for hand hygiene in healthcare settings. You perform hand hygiene immediately before touching a patient, before performing an aseptic task, like placing an indwelling device or handling invasive medical devices, before moving from work on a soiled body site to a clean body site on the same patient. Okay? After touching a patient or the patient's immediate environment, after contact with blood, body fluids, or contaminated surfaces, immediately after glove removal, before and after eating, and after using a restroom. And I have to say that because I cannot tell you how many times I go into a restroom. It doesn't even matter if it's just at a restaurant and people aren't washing their hands. You've got to make sure you wash your hands. So my 5 moments for hand hygiene. This is a model for hand hygiene that is used worldwide. Make sure you know this. The 5 moments are, again, before touching a patient, before a clean or aseptic procedure, after body fluid exposure, after touching a patient, and after touching a patient's surroundings. 5 moments of hand hygiene. We have something that's called aseptic non-touch technique, or ANTT. So aseptic technique must be followed for all clinical procedures associated with risk for infections. Okay, so this really includes virtually all infusion procedures. So ANTT is a globally accepted clinical practice framework, and it was originated by Stephen Rowley. ANTT was added as a new infusion therapy standard in 2021. And so what does that mean, an infusion therapy standard? We have the Infusion Nurses Society who puts out our standards and what guides the practice of infusion therapy. They included this ANTT as a therapy standard in 2021. That speaks volumes about the ANTT. There is often confusion and misunderstanding about terminology. It is important to understand that once a package is opened and sterile supplies are exposed to the air, the term asepsis or aseptic technique is used. No longer sterile, but aseptic technique, meaning absence for pathogenic organisms in sufficient quantity to cause infection. Because sterile means absence of all microorganisms, this is not achievable due to the presence of microorganisms in the air. Thus, once a sterile package is open, sterility cannot be assured. So I want you to think about this for a moment. Let's just talk about something simple like a 2x2 dressing. When that 2x2 is in its individual paper package, it is sterile. It's been processed, it's sterile, it is sterile. However, once you open that, you have now lost that sterility because of its exposure to air, and it now becomes aseptic. Okay, so I hope that makes sense. If you have any questions, just go ahead and reach out to me. But it is important for you to understand the difference between something that is sterile and something that is aseptic. Okay, so ANTT Clinical Practice Framework is based upon a unique concept called key part and key site. Each is achievable by integrating standard precautions such as hand hygiene and wearing appropriate PPE with aseptic fields and non-touch technique. And we're going to get into this just a little bit more, and it'll make more sense, okay? And it'll really come together when we're hands-on and we're using these terms and we're actually doing what we're supposed to be doing and we're talking about. But there are 5 practice terms you need to know. Those 5 practice terms include key part, and key part is any parts of the procedure equipment that, if contaminated, are likely to contaminate the patient. Examples include the tip of a syringe or IV tubing once the protective cap is removed. Another key part would be you're drawing blood and you're using a butterfly. Once that cap of the butterfly comes off, that cannula there becomes a key part. Another practice term is key site. This refers to the portal of entry, including the IV insertion site or where you're going to stick the needle in to draw blood. Another practice term is general aseptic field. A decontaminated and disinfected procedure tray or single-use procedure kit or a barrier upon which supplies are laid. So general aseptic field could be the bedside table you lay your drape on to put all your supplies, okay? Maybe your syringe, your test tubes, things like that. A microcritical aseptic field is a small protective sterile surface or housing to protect those key parts. Examples include caps or covers protecting a syringe or the mail-lure of the IV tubing until ready for use. Critical aseptic field is the 5th term, and that is your sterile drape or barrier upon which all procedure equipment is placed. Okay, so remember those 5 practice terms are key part, key site, general aseptic field, microcritical aseptic field, and critical aseptic field. Spend a few moments if you need to to make sure you understand those. Write them down on cards. You need to know those, okay? So when performing infusion procedures, additional terms include standard and surgical ANTT. Standard ANTT is adhered to when short, relatively straightforward procedures such as your VAD flushing or locking, changing administration sets, and IV medication administration. Okay. Standard ANTT includes adherence to standard precautions and protecting key parts and key sides by using non-touch technique and microcritical aseptic fields. So let's talk about what is a non-touch example. Well, that could be the cap of the tip of a saline flush syringe is removed when it is ready to be connected to the disinfected nasal cannula or not nasal or port on the IV tubing. Neither the syringe tip nor the NC is touched when the connection is made. So again, non-touch example would be, I'm going to take the tip of my syringe, my saline syringe off, and I'm going to insert it into the port that's been disinfected, and then nothing is touched. So that becomes a non-touch example. That you don't touch it, doesn't touch the counter, doesn't touch the table, you just connect it. Key part and key site rule is key parts must only come in contact with other aseptic key parts and key sites. If a key part or key site would require direct touch, sterile gloves are applied. Okay, so again, we can use the same example. The key parts in the above example would be your saline flush, and the key site would be your IV tubing, and they do not come in contact with other aseptic key parts unless the rules are applied. Surgical ANTT is adhered to when procedures are technically complex, involve many or large key parts, have a longer duration, and require higher levels of PPE. Examples include placement of that peripheral inserted catheter, like a PICC, or other central lines. Those are usually done in interventional radiology. That's why, surgical ANTT is used. Okay, not something you will be doing often. You will be doing standard, but just know that surgical ANTT does exist as well. Skin antisepsis. So this is what's done prior to the VAD placement. And this is part of the site care during catheter dwell time. And it is a critical step in reducing the risk for infection. Skin antisepsis is important because the bacteria on the skin at the insertion site can travel along the external surface of the catheter during the insertion and dwell time. So, you're going to start an IV and you're going to go ahead and clean that skin because you've got to make sure you're getting all the microorganisms off of that so you're not introducing them into the insertion site. So alcohol-based chlorhexidine or CHG solution, it's the standard of practice now. There was a time where we used to use PVP iodine and then cleaned it with a regular alcohol, and so it was all these steps, but now we're using just a chlorhexidine solution to clean the area, unless of course someone's allergic to it. And we let it dry completely. We don't want to introduce that into the body when we start the IV or draw blood, but we make sure that it's dried completely, but we do use that chlorhexidine. So INS standards, and again, INS is the Infusion Nurses Society, provide guidance for preterm neonates and low birth weight infants within the first 14 days of life. Now, I did put a little bit here, and we're not going to go into that because, for preterm neonates and low birth weight, those are usually your RNs, but you just be aware that we do have special solutions for them as well. Additional important aspects of skin preparation include the following: Antimicrobial solutions in a single unit use configuration should be used. What that means is that usually you get, and you'll see this when we go to do this, it's a one stick thing. It's a, it comes in multiple forms, and they're usually where you crack them, and then the solution comes to the head, and that's all the head of the swab, and that's all you use, and it's a single use, and you throw it away. Alcohol should not be applied after the application of the providon iodine preparation because alcohol negates the effects of PVP iodine. We've learned that over the years. Again, there was a time when we used to do that, but not anymore. The antimicrobial preparation should be allowed to air dry completely before proceeding with the VAD insertion or drawing blood. Because again, we do not want to, that burns, it burns bad. So we got to make sure that dries, and we're not going to help it dry by waving our hand over it or definitely not blowing on it. Just going to let it dry. It only takes a few seconds. Let it dry completely before you move on. Catheter dressings. Maintain a clean, dry, and occlusive dressing is important in protecting the catheter insertion site and reducing the risk of infection. A dressing is placed over the time of catheter insertion and is regularly changed as part of the overall site care procedure. Okay, and we'll talk more about the changing of that dressing, but just know for infection control, it is changed regularly. This is a busy slide. I'm not going to go into it. I'm going to have you pause the recording and read it. You just, know that if it's a like a PIC, some type of central line, it's every 7 days we change it. It depends on the type, the patient. So, if the patient's wearing a gauze dressing because maybe they're allergic to the tegaderm or whatever, then that's done every 2 days because our gauze dressings, they could have drainage. They could be very sweaty. So we just have to take into consideration what is going on with the patient. So these chlorhexidine dressings include a small round foam dressing that incrementally releases the CHG. It is placed around the catheter at the exit site. So this is what it looks like. So you can see, and this is usually used for PICs, but you need to see what this looks like so you will know that this is a disc. It's an impregnated disc with CHG, and it's put around, and it's changed every time your dressing is changed. So it's taken off. The skin is cleansed under. The skin is cleansed under that insertion site, and at that point, a new bio patch is put on, and then the dressing is put over that. So, like it's usually like a tegaderm. Sometimes, we're finding more and more organizations using a transparent semi-permeable membrane dressing where the dressing itself is impregnated. So there's like little pieces in the dressing that have the CHG to help keep that clean. So VAD securement. Securement is an important step in the care of VADs, including PIVCs and non-tunneled CIVs and PICs. So it doesn't matter what kind of line, whether it's just a regular IV, a central line, or a PIC, they have to be secured. So limiting the movement of the catheter in and out of the insertion site, which that is called pistoning, it reduces the risk for accidental dislodgement and other complications, including something called infiltration, phlebitis, and of course infection. And we're going to talk about inflammation and phlebitis in a different lecture. Relative to the risk of infection, catheter movement in and out of the insertion site allows pathogens on the skin to migrate into the catheter tract. Think about a Foley. Think about when that Foley is not cleaned and the microorganisms crawl right up that tube and into the bladder, and guess what? We have a bladder infection, right? So same thing can happen here. So that's why, cleanliness has to be first and foremost to reduce that risk of infection. Needleless connectors, okay? So needleless connectors, it's an important aspect of infection prevention. And so when we talk about a needleless connector, what we're talking about is the like an IV tubing into where it actually goes into the IV. So if there's a failure to cleanse that or disinfect, the germs that you could introduce are phenomenal, and it'll lead to infection. Now, with needleless connectors, there is either an active or a passive disinfection, that to cleanse those. Um, you can use either or, it depends on your organization. So let's talk about them. So what is active disinfection? So that means it's just and you've all seen it, it's a vigorous cleaning. So the nurse comes in and takes alcohol and rubs that site, before she connects the IV to it. So that is your active disinfection. That is, we take an alcohol swab, rub the end like crazy, and then hook up our IV. You've all seen it. Now there's a passive disinfection. We put a picture here for you where it's a cap. So you can see in the picture what happens is, and these caps are one-time use, one and done, they throw away. I wish I would have invented this back in the day when the IV therapy was all I did, and we had to use like the tip of the syringe to cover the end of the tubing and things like that, and then of course cleanse before we reused them. Well, somebody, evidently smarter than me, came up with this cap, and all you do is take that cap and you put the end of your tubing from your IV in there, and the inside of that cap is impregnated with CHG, and it keeps that tubing nice and clean. And then when you go to rehook up that IV, you just take that cap off, throw it away, hook up, and you're done. It's a beautiful system. So very, 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 very economically sound, reduces the risk of infection, and again, it's impregnated with CHG. So your catheter does not require the scrubbing like it would if you didn't have this. So these are wonderful. And there's different colors. They now look different. I've seen some blue, they're orange, all different colors. So it just depends on who's making them, but you will see these. Okay, the administration set management. So again, ANTT is adhere to at all times when changing the administration tubing. Um, Again, recognizing the VAD hub and the male lure of the administration set as key parts. Okay, and again, make more sense when we get into what these parts are. But in the interim, you just have to understand that administration set is a key part, and we have to make sure that it stays clean and that we're making sure we're using aseptic techniques, and that we're changing those sets every 24 hours because of infection and things like that. So we just administration set management and administration set is key parts. So I want to make sure that you're aware of that. So additional recommendations for the frequency of administration set. Again, they include, to be changed every 24 hours. If this is, if it's a fat emulsion set, then it's 12 hours. Depending on, if it's IV fluids, it could last longer. It could go, 3 days to 7 days. It just depends on your institution. So there's sometimes we have filters, you'll see those. You're going to follow your institutional policy on how often you change this. And those policies are based on best practice and, evidence-based practice, which the INS the standards guide that. So just know you will follow your agency's policy on changing the frequency of these administration sets. And again, remember, administration sets are your key parts. Patient education. Well, we're always educating the patient, right? Always, always, always. We're going to educate them regarding any complications and management, to be careful if they're shifting in bed. If we're just drawing blood, it's a in and out thing. We're going to make sure that they know to keep the bandage on there for a couple hours. Um, so it's just making sure that we individualize those instructions to the patient, and we do that with everything we do. So that shouldn't come as a surprise. We want to include things like hand hygiene, just kind of remind them that, if we've working with an IV, that they need to be concerned about, the concept of clean and dirty and sterile. And then we also want to make sure that they're adhering to whatever the prescribed antibiotics is. We're going to talk to them about dressing changes, signs and symptoms to report if you're in home care or if they're in hospital. Something doesn't feel right, that you go to flush it, doesn't feel right. They need to make sure that they're letting us know, okay? So let's just talk a few seconds about phlebotomy. Then, so phlebotomy is drawing blood. You all know that, and a lot of you will be, doing that the majority of the time. A couple of things we want to make sure, you assemble your equipment and you want to place it within easy reach on a tray. Key parts, remember, because you want them clearly visible so you're not having to cross over once you clean your insertion site where you're going to do the blood draw. You want to make sure everything is within your reach and easy to get to. You want to identify and prep the patient, because we all know we don't want to be sticking the wrong patient and drawing blood on the wrong patient. So again, just like anything we do with a patient, we're going to introduce ourselves. We're going to have everything prepped. We're going to talk to the patient, make sure there's no allergies, because of course we don't want to put, a bandage on them that they're going to, have a reaction to. We're going to, depending on the environment, we're going to try to have them in a comfortable sitting position. We're going to put something under their arm, again, depending on the environment. And then we're just going to make sure that they understand what we're doing, and if possible, get verbal consent for what we're doing. You're going to select the site. We're going to go into great detail on how to select the site. One of the things is, you want to make sure your vein is visible. It may include, having them dangle their arm down. You apply a tourniquet. You want to have it 4 to 5 finger widths above the venipuncture site where you're, going to be sticking. Hospitalized patients, it may not be as easy to get them to sit and dangle their arms, but we do have to remember that we, do not want to draw blood from an existing IV site. It's going to be a separate blood draw. It may contaminate your results. Now, other nurses, depending on what they're doing, or physicians may access central lines to do that. Again, we just don't want to do it the first time we draw blood. So again, perform hand hygiene, put on your gloves. You're going to wash your hands with soap and water and dry with paper towels. If your hands are not visibly contaminated, you by all means can use an alcohol rub, foam, gel-based, doesn't matter. And then you're going to go ahead and put your gloves on, non-sterile. You're going to disinfect the entry site. And this is, unless you're drawing blood cultures, you're just going to prep. You're going to clean with that 70% alcohol for about 30 seconds and let it to dry completely, about another 30 seconds. We're going to go into the procedure in more detail, but this is just how we're going to maintain infection control precautions. We're going to make sure when we clean, it's going to be a firm but gentle pressure. And again, we're going to start from the center of where we think we're going to stick and work outside. So it's a circular motion or back and forth for 2 centimeters or more. Again, let it dry. Let it air dry. Do not rub your hand above it. Do not blow on it. If you do not allow enough contact time for cleaning, you could increase, the risk for contamination. You do not want to touch that site once you've cleaned it, okay? So you just want to make sure you know exactly what you're doing, where your vein is and how it's running, and then we're going to clean it, and then we're going to stick it after it dries. And then we're going to go ahead and we're going to anchor the vein, and we're going to get all this into, but again, for infection precautions, you're going to anchor it below the venipuncture site, okay? If we don't do it below, we do run the risk of introducing microorganisms. Even though our hands are gloved, they're still